Why are you interested in working in the PICU specifically? What draws you to critical care for children?
My passion for pediatric critical care stems from both my clinical experiences and a deep sense of purpose in serving critically ill children and their families. The PICU is a unique environment where every moment counts, and the ability to make a meaningful difference in a child's life, especially during their most vulnerable moments, is incredibly rewarding. What draws me most to the PICU is the complexity of care required for these young patients. Unlike other units, the PICU demands not only advanced clinical skills but also a high level of emotional resilience and adaptability. Children respond differently to illness and treatment compared to adults, and I find it both challenging and fulfilling to tailor interventions to their specific needs while supporting their families through such difficult times. Additionally, I thrive in fast-paced, multidisciplinary settings where teamwork is essential. The PICU fosters collaboration among doctors, nurses, respiratory therapists, and other specialists, all working toward the shared goal of stabilizing and healing critically ill children. Being part of such a dedicated team, where every decision can have a profound impact, aligns perfectly with my professional values. Ultimately, my motivation comes from seeing the resilience of these children and the gratitude of their families. Even in the most intense situations, the opportunity to provide compassionate, evidence-based care and contribute to positive outcomes is what makes the PICU the right place for me.
Tell me about your experience in pediatric nursing. Have you had any previous critical care experience? If so, describe it.
My experience in pediatric nursing spans over 10 years, during which I've had the privilege of caring for children across various age groups and acuity levels. I began my career in a general pediatric ward, where I developed a strong foundation in assessing and managing common childhood illnesses, administering medications, and providing family-centered care. Working closely with children and their parents in this setting honed my ability to communicate effectively, ease anxieties, and educate families on treatment plans and recovery. As my passion for high-acuity care grew, I transitioned into a pediatric step-down unit, where I managed patients with more complex conditions, such as respiratory distress, post-operative recovery, and chronic illnesses requiring close monitoring. This experience strengthened my skills in interpreting vital signs, recognizing early signs of deterioration, and intervening promptly, skills that are crucial in critical care settings. My most significant experience has been in the Pediatric Intensive Care Unit, PICU, where I've spent the past 7 years caring for critically ill children, including those with severe respiratory failure, sepsis, traumatic injuries, and post-cardiac surgery recovery. In the PICU, I've become proficient in operating advanced equipment such as ventilators, infusion pumps, and continuous monitoring systems. I've also been involved in emergency interventions, including rapid responses and code situations, where teamwork and quick decision-making are vital. One particularly impactful case was managing a toddler with severe pneumonia who required intubation and careful hemodynamic monitoring. Collaborating with the multidisciplinary team to stabilize the child, adjust ventilator settings, and support the distraught parents reinforced my commitment to PICU nursing. The balance of technical expertise, compassion, and resilience required in critical care is what drives me to continue growing in this specialty. Overall, my background has equipped me with the clinical competence and emotional strength needed to thrive in high-stakes pediatric environments, and I'm eager to bring this experience to your team.
What are your strengths that you feel would be particularly valuable in the PICU setting?
I believe my greatest strengths in the PICU setting are my clinical vigilance, adaptability under pressure, and compassionate family-centered care. Having worked in pediatric critical care for 5 years, I've developed a keen ability to monitor subtle changes in a child's condition, whether it's a slight variation in vital signs, lab results, or behavior, and respond proactively. In the PICU, early recognition of deterioration can be life-saving, and my attention to detail ensures I act swiftly to escalate concerns or adjust care plans. Another strength is my ability to remain calm and focused during emergencies. The PICU often demands rapid decision-making in high-stress situations, such as coding a patient or managing a sudden decompensation. My experience in these scenarios has taught me to prioritize effectively, follow protocols precisely, and communicate clearly with the team to ensure seamless collaboration. I also recover and reflect after critical incidents, which helps me maintain resilience and continuous improvement. Beyond technical skills, I take pride in my ability to support families during incredibly difficult times. Parents in the PICU are often overwhelmed, and I've found that clear communication, emotional support, and small acts of kindness, like explaining procedures in simple terms or creating a calming environment, can make a profound difference. I actively listen to their concerns, involve them in care when possible, and advocate for their child's needs. Lastly, I thrive in interdisciplinary environments and value the expertise of each team member, whether it's consulting with respiratory therapists on ventilator settings or collaborating with physicians on complex cases. My teamwork-oriented mindset helps foster a cohesive unit where patient safety and outcomes come first. These strengths, clinical acuity, composure in crises, empathy for families, and collaborative spirit, are what I bring to the PICU every day.
What are your weaknesses, and how do you actively work to improve them?
One area I've been consciously working on is delegating tasks when overwhelmed. In high-stress environments like the PICU, my instinct is to take on as much as possible to ensure nothing is missed, but I've learned that this can lead to burnout or missed opportunities for team growth. To improve, I've started proactively communicating with colleagues during shifts, asking for help when needed, and trusting others to handle tasks appropriately. For example, I now make it a habit to brief my team if I'm managing a critical patient and need support with documentation or medication prep. This not only balances my workload but also fosters teamwork. Another weakness I've identified is my tendency to be overly self-critical, especially after challenging outcomes. While reflecting on cases is important for growth, I've realized that excessive doubt can hinder confidence in future decisions. To address this, I've begun discussing cases with mentors to gain perspective, focusing on lessons learned rather than dwelling on what I couldn't control. Additionally, I practice mindfulness techniques to manage stress and maintain a healthier mindset. These efforts have already made a difference. I'm now more collaborative and resilient while still holding myself to high standards. I see this as an ongoing process and welcome feedback to continue growing.
How do you handle the emotional demands of caring for critically ill children and their families?
Caring for critically ill children and their families is undoubtedly emotionally challenging, but I've developed strategies to manage these demands while maintaining both professionalism and compassion. First, I remind myself that being emotionally present is a strength. It allows me to provide genuine comfort and build trust with families during their most vulnerable moments. However, I also recognize the importance of setting healthy emotional boundaries to avoid burnout and ensure I can continue giving my best to every patient. One way I cope is by focusing on what I can control, delivering excellent clinical care, advocating for my patients, and offering consistent emotional support to families through clear communication and small acts of kindness. For example, I might sit with a parent to explain a procedure in simple terms or create memory keepsakes for families in palliative cases. These moments reinforce the meaningful impact we can still make, even in difficult situations. After particularly tough shifts, I practice self-reflection and decompression. I might debrief with a trusted colleague or mentor, which helps process emotions and gain perspective. I also prioritize self-care outside of work, whether through exercise, hobbies, or spending time with loved ones, to recharge emotionally. Ultimately, I see the emotional weight of this work as a testament to its importance. While I don't hide my empathy, families appreciate knowing their child's nurse truly cares. I've learned to channel those feelings into purposeful action. Over time, this balance has helped me remain resilient and dedicated in the PICU.
Where do you see your career in pediatric critical care progressing in the next 5 years?
In the next 5 years, I envision myself growing into a more specialized and leadership-focused role within pediatric critical care while remaining deeply connected to bedside nursing. My goal is to pursue advanced certifications like Pediatric Critical Care Nursing, CCRNP, and potentially a clinical specialty in areas like pediatric cardiac critical care or neurocritical care, depending on the needs of the unit. I'm particularly interested in mastering advanced hemodynamic monitoring and ECMO management to contribute at a higher level during complex cases. Beyond clinical expertise, I'd love to take on mentorship roles, guiding newly graduated nurses or less experienced PICU staff. Seeing how much I benefited from supportive preceptors early in my career, I want to pay that forward by fostering a culture of teamwork and continuous learning. Long term, I'm also open to contributing to quality improvement projects or hospital committees focused on evidence-based practice in critical care. Whether it's streamlining emergency protocols or improving family support programs, I want to help shape care standards that benefit both patients and staff. That said, my heart remains at the bedside. Even as I grow, I aim to stay clinically engaged because direct patient care is why I chose this specialty. Ultimately, I hope to balance hands-on nursing with leadership opportunities that elevate the entire PICU team.
What motivates you as a pediatric nurse?
What motivates me most is the incredible resilience of children, even in the face of serious illness, and the privilege of being part of their healing journey. In pediatrics, small victories carry profound meaning: a child breathing independently after days on a ventilator, a toddler smiling again after surgery, or a parent finally exhaling with relief. Those moments remind me why this work matters. I'm also driven by the unique trust families place in us during their most vulnerable times. When parents hand me their critically ill child, that responsibility fuels my commitment to provide not just expert care, but also compassion and reassurance. In the PICU, we often care for children for weeks or months, and forming those bonds, celebrating milestones in recovery, or offering comfort in difficult moments, makes this more than a job, it's a calling. On tougher days, what keeps me going is the team. Collaborating with colleagues who share the same dedication, whether problem-solving a complex case or supporting each other after a loss, reinforces that we're never alone in this work. Ultimately, my motivation comes from believing that even on the hardest days, we can make a difference. Whether it's through life-saving interventions or simply holding a child's hand during a painful procedure, pediatric nursing lets us bring light to some of life's darkest moments.
Why are you interested in working at our specific PICU? What do you know about our unit?
I'm deeply interested in joining your PICU because of its reputation for excellence in both clinical outcomes and family-centered care. From my research and conversations with colleagues, I understand your unit is a leader in cardiac critical care. Your team's commitment to evidence-based practice and innovative treatments aligns perfectly with my passion for advancing my skills in high-acuity pediatric care. What truly stands out to me is your unit's emphasis on multidisciplinary rounds. For example, I read about your specific award project, which demonstrates how your team goes beyond medical treatment to address the holistic needs of patients and families. As a nurse who values both technical expertise and compassionate care, I'm eager to contribute to this environment. Additionally, I admire your focus on professional development/education, e.g., residency programs. I'm particularly excited about the chance to grow here through the ECMO specialist training or mentorship program. Ultimately, I want to work in a PICU that challenges me clinically while fostering a collaborative culture, and from what I've learned, your unit embodies those values. I'd be honored to bring my dedication to this team and learn from the exceptional nurses and physicians here.
Describe your experience with common PICU equipment, e.g., ventilators, monitors, infusion pumps.
Throughout my experience in the PICU, I've developed strong proficiency with the specialized equipment critical to managing pediatric patients. With ventilators, I'm skilled in managing both invasive and non-invasive modes, including conventional ventilation, high-frequency oscillatory ventilation, HFOV, and CPAP/BiPAP. I'm comfortable adjusting settings like PEEP, FiO2, and tidal volumes based on ABGs and clinical response, and I prioritize regular assessments to prevent complications like volatrauma or atelectasis. For hemodynamic and neurological monitoring, I routinely work with advanced systems like continuous EEG, ICP monitors, and arterial lines. I'm adept at interpreting waveforms, recognizing subtle changes, such as dampened arterial traces or rising ICP, and responding promptly. I also use cardiac output monitoring devices, PICU, to guide fluid and vasoactive drug administration in shock states. With infusion pumps, I frequently manage multiple drips, including vasopressors, inotropes, sedatives, and insulin, ensuring precise titration to avoid dosing errors. I'm meticulous about labeling lines, using smart pumps with dose error reduction systems, and double-checking high-alert medications. Beyond operation, I emphasize safety, like daily ventilator checks, preventing tube dislodgement in active children, and troubleshooting alarms efficiently to avoid alarm fatigue. My goal is always to blend technical expertise with vigilant, patient-centered care.
How comfortable are you with interpreting hemodynamic monitoring?
I'm very comfortable interpreting hemodynamic monitoring, as it's a critical part of my daily practice in the PICU. I routinely work with arterial lines, central venous pressure, CVP, monitoring, and advanced tools like PICU or NIRS, near-infrared spectroscopy, to assess perfusion and cardiac output. For example, I track trends in parameters such as stroke volume variation, SVV, cardiac index, and systemic vascular resistance, SVR, to guide fluid resuscitation and vasoactive drug titration in septic or postoperative cardiac patients. Interpreting waveforms is second nature to me, whether it's recognizing a dampened arterial trace suggesting an underdamped system or identifying elevated CVP waveforms that might indicate tamponade or fluid overload. I also correlate hemodynamic data with clinical signs, e.g., capillary refill, urine output, and lab results, lactate, mixed venous saturation, to form a complete picture of the child's status. In critical situations like septic shock or post-cardiac arrest, I prioritize rapid, data-driven decisions. For instance, if a patient's MAP is low but their CVP is high, I'd consider diuresis or inotropes rather than fluids. I'm also diligent about troubleshooting artifacts or transducer issues to ensure accuracy. While I'm confident in my skills, I stay curious. I regularly discuss complex cases with our cardiology team and attend workshops to refine my knowledge of newer technologies like echocardiography-assisted monitoring.
Discuss your understanding of fluid and electrolyte management in critically ill children.
Fluid and electrolyte management in critically ill children requires meticulous precision because even small imbalances can have profound consequences due to their smaller blood volumes and metabolic differences compared to adults. My approach is guided by three key principles: restoration of perfusion, avoidance of fluid overload, and targeted electrolyte correction, all while considering the child's unique physiology. In resuscitation phases, I prioritize isotonic fluids, e.g., NS or LR, for hypovolemic or septic shock, but with strict attention to weight-based volumes, e.g., 10 to 20 ml/kg boluses, and frequent reassessment for signs of fluid responsiveness, e.g., improved HR, UOP, or lactate clearance. I'm cautious with hypotonic solutions, as children are at higher risk for hyponatremia and cerebral edema. For maintenance fluids, I adjust for insensible losses, higher in febrile or intubated patients, and renal/hepatic comorbidities. I use tools like Holiday-Seeger or 4-2-1 rules as starting points but tailor them based on ongoing losses, e.g., gastric drains, diarrhea, and serum electrolytes. For example, in a child with diabetic ketoacidosis, I'd gradually correct sodium and glucose while avoiding rapid shifts that could risk cerebral edema. Electrolyte imbalances demand rapid but controlled intervention. For hyperkalemia with ECG changes, I'd administer calcium gluconate, insulin glucose, and albuterol while preparing dialysis if needed. In SIADH, I restrict fluids and may use 3% saline cautiously. I also monitor for refeeding syndrome in malnourished patients initiating nutrition. Ongoing monitoring is critical, tracking daily weights, strict INOS, and trends in labs, e.g., Na+, K+, Mg2+, phosphate. In cardiac or renal patients, I collaborate closely with the team to balance fluid removal, e.g., diuretics or CRRT, with perfusion needs. Ultimately, my goal is to maintain homeostasis while recognizing that children's needs evolve rapidly. What's appropriate in the first 24 hours of septic shock may shift to fluid restriction by day 3 to avoid pulmonary edema.
Describe your experience with different modes of ventilation and their indications.
In the PICU, I've managed a wide range of ventilatory modes, tailoring support to each child's pathophysiology while prioritizing lung protective strategies. My experience includes both conventional and advanced modes, with a focus on optimizing oxygenation and ventilation while minimizing barotrauma and volotrauma. For invasive ventilation, I frequently use pressure control, my go-to for most pediatric patients, especially those with acute respiratory distress syndrome or postoperative cardiac cases, as it limits peak pressures and reduces barotrauma risk. I adjust inspiratory pressure and PEEP based on oxygenation and compliance. Volume control, reserved for patients with stable lung compliance, e.g., neuromuscular disease, ensuring consistent tidal volumes. I closely monitor plateau pressures to avoid overdistension. Pressure-regulated volume control, a hybrid mode I often use for patients with fluctuating compliance, e.g., asthma exacerbations, as it delivers a set tidal volume at the lowest possible pressure. In refractory hypoxia or ARDS, I transition to high-frequency oscillatory ventilation, for severe ARDS with P-F ratios less than 100, using small tidal volumes and high mean airway pressures to recruit alveoli while limiting cyclic trauma. I titrate amplitude and frequency based on CO2 clearance and chest wiggle. Airway pressure release ventilation, for older children with focal lung disease, as it improves recruitment through prolonged inspiratory times, thigh, and brief releases, flow. For non-invasive support, I apply CPAP/BiPAP, for mild respiratory failure, e.g., bronchiolitis, or post-extubation support, adjusting pressures to reduce work of breathing while monitoring for gastric distension or skin breakdown. Weaning phases involve transitioning to pressure support ventilation, PSV, to assess readiness for extubation, gradually reducing support as the child takes spontaneous breaths. A recent example, I managed a 5-year-old with severe ARDS using HFOV, optimizing oxygenation by incrementally increasing mean airway pressure while keeping FiO2 less than 60%. After 72 hours, we transitioned to PCV with prone positioning, ultimately achieving extubation.
How do you approach pain management and sedation in pediatric critical care?
Managing pain and sedation in critically ill children requires a delicate balance between ensuring comfort and maintaining hemodynamic stability while avoiding oversedation or withdrawal. My approach is rooted in evidence-based protocols, continuous assessment, and individualized care tailored to each child's clinical condition and developmental stage. I begin with thorough pain assessments using validated tools like the FLAX scale for infants or the Wong-Baker FACES scale for older children, adjusting for nonverbal patients with cognitive impairments. For procedural pain, such as line insertions or dressing changes, I prioritize non-pharmacologic interventions like swaddling, sucrose for neonates, or distraction techniques, combined with topical anesthetics like lidocaine. When pharmacologic sedation is needed, I follow a stepwise approach. For mild pain or anxiety, I might use low-dose opioids like morphine or fentanyl, paired with non-opioid adjuncts such as acetaminophen or ibuprofen to minimize opioid exposure. In mechanically ventilated patients requiring deeper sedation, I titrate medications like dexmedetomidine for its hemodynamic stability or midazolam for its rapid onset, always using the lowest effective dose to achieve calm but arousable sedation. I'm particularly vigilant about iatrogenic withdrawal syndrome in children on prolonged sedation. To mitigate this, I use daily sedation vacations when clinically appropriate, gradually weaning infusions while monitoring for signs of distress or withdrawal. For example, in a toddler on a fentanyl drip post-cardiac surgery, I collaborated with the team to transition to enteral methadone, ensuring a smoother taper. Regular reassessment is critical. I document sedation scores, e.g., state behavioral scale, and pain responses hourly, adjusting plans based on vital signs, ventilator synchrony, and family feedback. I also educate parents about sedation goals and involve them in comfort measures like holding their child's hand during procedures. Ultimately, my goal is to keep children safe, comfortable, and as interactive as possible, because even in critical illness, their emotional and developmental needs matter.
What is your understanding of the pathophysiology and management of common PICU conditions, e.g., sepsis, ARDS, DKA, status epilepticus?
My experience in the PICU has given me a deep understanding of the pathophysiology and evidence-based management of critical pediatric conditions, each requiring tailored interventions to address their unique mechanisms and complications. Sepsis begins with a dysregulated host response to infection, leading to systemic inflammation, endothelial damage, and microthrombi formation. This cascade results in distributive shock, with hypotension, lactic acidosis, and organ dysfunction. Management hinges on early recognition using PSOFA scores, prompt broad-spectrum antibiotics, and aggressive fluid resuscitation with crystalloids, 20 ml per kilogram boluses. I closely monitor for fluid overload, transitioning to vasopressors like norepinephrine if perfusion remains inadequate, while prioritizing source control, e.g., draining abscesses. Adjunctive therapies like steroids may be considered in refractory shock. ARDS is characterized by diffuse alveolar damage, increased permeability, and non-cardiogenic pulmonary edema, leading to severe hypoxemia, P/F ratio less than 300. Ventilator management focuses on lung protective strategies, low tidal volumes, 4 to 6 ml/kg, moderate PEEP to prevent atelectrauma, and permissive hypercapnia. I've managed severe cases with prone positioning and neuromuscular blockade to improve V/Q matching, while avoiding fluid overload to reduce pulmonary edema. In refractory cases, I've collaborated with teams to initiate ECMO as a rescue therapy. DKA involves insulin deficiency, triggering lipolysis, ketogenesis, and a metabolic acidosis with profound dehydration. Cerebral edema is a lethal risk, so I avoid rapid fluid boluses, using 10 ml per kilogram NS initially, and correct hyperglycemia gradually, target glucose decline less than 100 mg per deciliter per hour. Insulin infusions, 0.05 to 0.1 units/kg/hr, are started only after confirming adequate potassium, greater than 3.3 milliequivalent/L, to avoid arrhythmias. I monitor neurologic status vigilantly for signs of cerebral edema, e.g., headache, bradycardia, ready to escalate to mannitol or hypertonic saline if needed. Status epilepticus is a neurological emergency with sustained seizures causing neuronal injury and metabolic derangements. First-line treatment includes benzodiazepines, for lorazepam or midazolam, followed by fosphenytoin or levetiracetam for persistent seizures. I secure the airway early, monitor for respiratory depression, and initiate continuous EEG to detect nonconvulsive seizures. For refractory cases, I've assisted with propofol or midazolam infusions, titrated to burst suppression while maintaining hemodynamic stability. Underlying causes, e.g., infections, metabolic disorders, must be identified and treated concurrently. Across all conditions, I emphasize multidisciplinary collaboration, frequent reassessment, and family-centered care. For example, in sepsis, I educate parents about early warning signs, while in DKA, I involve them in monitoring for cerebral edema symptoms. My goal is to integrate pathophysiology knowledge with rapid, precise interventions to optimize outcomes for these vulnerable children.
How do you assess and manage a deteriorating pediatric patient? Walk me through your steps.
When recognizing a pediatric patient in distress, my response follows a structured yet fluid approach that balances urgency with precision. I begin with an immediate ABC assessment, evaluating airway patency, quality of breathing, and circulatory status while simultaneously attaching monitoring equipment. Children often compensate remarkably well before sudden deterioration, so I pay particular attention to subtle warning signs like prolonged capillary refill, altered mental status, or increasing work of breathing. These can be early indicators of impending crisis before vital signs dramatically change. If the airway is compromised, I initiate appropriate maneuvers while preparing for potential advanced airway management. For respiratory distress, I escalate oxygen therapy judiciously, always anticipating the possible need for mechanical ventilation. When facing circulatory compromise, I administer calculated fluid boluses while preparing vasoactive medications, being mindful of the delicate balance between adequate resuscitation and fluid overload in pediatric patients. Simultaneously, I conduct a rapid diagnostic evaluation, synthesizing the patient's history with current clinical findings. This might involve checking point-of-care glucose in an altered patient or listening for absent breath sounds in a suddenly hypoxic child. I recall a recent case where this systematic approach helped me identify cardiac tamponade in a post-operative patient, prompting immediate intervention. Communication becomes paramount at this stage. I use structured SBR format to alert the team while clearly delegating tasks to ensure coordinated care. After initial stabilization, my focus shifts to continuous reassessment and anticipation of complications, adjusting ventilator settings to protect fragile lungs or titrating vasopressors based on invasive monitoring. Throughout this process, I maintain transparent communication with the family, explaining interventions in terms they can understand while providing emotional support during this stressful time. This comprehensive approach, combining rapid assessment with thoughtful intervention and clear communication, allows me to provide optimal care during critical situations while maintaining the teamwork and family-centered approach essential in pediatric critical care. This version maintains all the key clinical points while presenting them in a more cohesive, narrative format that flows naturally as a spoken response. The technical details are preserved but woven into a more conversational structure that would be appropriate for an interview setting.
Describe your experience with central line and arterial line management.
Throughout my experience in the PICU, I've developed a comprehensive approach to managing central lines and arterial lines, prioritizing both clinical efficacy and infection prevention. Central lines are indispensable for administering vasoactive medications, parenteral nutrition, and frequent blood sampling, while arterial lines provide real-time hemodynamic monitoring and accurate blood pressure measurement in critically ill children. My responsibilities begin with insertion assistance, where I ensure strict sterile technique, prepping the site with chlorhexidine, maintaining a sterile field, and verifying catheter placement via X-ray or ultrasound. I'm proficient in dressing changes using transparent semi-permeable dressings, which I replace every 7 days or immediately if compromised, always using a septic technique to minimize CLABSI, central line-associated bloodstream infection, risk. For daily maintenance, I adhere to hub scrubbing protocols with alcohol or chlorhexidine before accessing lines, and I minimize unnecessary manipulations by bundling blood draws or medication administrations. I routinely assess for complications like thrombosis or infiltration. For instance, I recently identified a malpositioned PICC line in a neonate by noting resistance during flushing and promptly escalated it for imaging. With arterial lines, I zero and level transducers hourly to ensure accuracy, especially when managing shock or post-cardiac surgery patients. I'm vigilant about waveform interpretation, recognizing dampened traces that may indicate clotting or dislodgement, and I troubleshoot issues like kinked tubing or air bubbles. To prevent ischemia, I perform regular neurovascular checks in limbs with arterial access. Safety and infection control are paramount. I advocate for daily line necessity reviews with the team to discontinue lines as soon as possible. I also educate families on line precautions, such as avoiding tugging on tubing. A recent example, I managed a septic toddler with a femoral central line and radial arterial line. By meticulously maintaining both lines, including frequent site assessments and sterile dressing changes, we avoided infections and gathered critical hemodynamic data to guide fluid and vasopressor therapy, contributing to the child's recovery.
How do you calculate and administer medications, including vasoactive drips, in the PICU setting?
Medication administration in the PICU requires meticulous precision, especially when dealing with high-risk medications like vasoactive drips, where even minor errors can have significant consequences. My approach is systematic, combining standardized protocols with double-check safeguards to ensure patient safety. For dose calculations, I always use weight-based formulas, mg/kg or mcg/kg, and confirm the child's most recent weight, cross-referencing it with the medical record to account for fluid shifts or nutritional changes. With vasoactive drips like norepinephrine or epinephrine, I calculate the concentration in mcg/kg/min, using programmable infusion pumps with preset libraries to minimize manual entry errors. For example, when initiating a dopamine drip at 5 micrograms per kilogram per minute for a 12 kilograms child, I'd prepare a standardized concentration, e.g., 60 mg in 50 ml D5W, and program the pump to deliver exactly 0.5 ml per hour to achieve the desired dose. Preparation follows strict aseptic technique, with independent double checks by a second nurse for high-alert medications, confirming the drug, dose, dilution, and infusion rate before administration. I label all lines clearly, including drug name, concentration, and expiration time, and use dedicated lumens for vasoactives to avoid incompatible co-administrations. During titration, I adjust doses based on continuous hemodynamic monitoring, e.g., MAP, UOP, lactate, and prescribed parameters, documenting every change with the time, dose, and clinical response. For instance, if a septic patient on norepinephrine remains hypotensive despite 0.1 micrograms per kilogram per minute, I'd escalate in 0.05 micrograms per kilogram per minute increments while reassessing for volume status or alternative therapies. Safety nets include using smart pumps with dose error reduction systems, DERIS, routine line patency checks to prevent extravasation, and immediate discontinuation of vasoactives via central lines if infiltration is suspected. I also educate families about the purpose of drips and monitor for adverse effects, e.g., arrhythmias with epinephrine. Ultimately, my goal is to merge pharmacokinetic expertise with vigilant oversight, ensuring that every medication, whether a routine antibiotic or a life-saving vasopressor, is delivered accurately and responsibly.
Discuss your knowledge of different scoring systems used in the PICU, e.g., PALS, Glasgow Coma Scale, PRISM.
In the PICU, scoring systems are essential for standardizing assessments, predicting outcomes, and guiding clinical decisions. My experience with these tools ensures I can quickly evaluate a child's condition and communicate effectively with the multidisciplinary team. The Pediatric Advanced Life Support (PALS) algorithms provide a structured approach to managing critical events like cardiac arrest or respiratory failure. I use PALS guidelines to prioritize interventions, such as identifying shock types, hypovolemic, distributive, cardiogenic, or determining when to escalate to advanced airway management. For example, during a code, I follow the systematic assess categorize intervene reassess framework, ensuring timely epinephrine administration in non-shockable rhythms or appropriate fluid resuscitation in septic shock. For neurological assessment, the Glasgow Coma Scale, GCS, adapted for pediatrics and infants, is my go-to tool. I evaluate eye-opening, verbal response, and motor activity, recognizing that even subtle changes in scores, e.g., a drop from 11 to 8, can signal deterioration requiring immediate imaging or intervention. In intubated patients, I document the modified GCS with a T to indicate the limitation in verbal scoring. The Pediatric Risk of Mortality, PRISM, for score helps quantify illness severity upon admission. By evaluating variables like systolic blood pressure, arterial oxygen partial pressure to fractional inspired oxygen ratio, and pupillary reflexes, I contribute to data collection that predicts mortality risk and supports family discussions about prognosis. I also use pediatric early warning scores, PEWS, for ongoing monitoring, as trends in heart rate, respiratory effort, and capillary refill can prompt early escalation before a child deteriorates. Additionally, I'm familiar with pain scales, FLAC, Wong-Baker faces, and sedation scores, state behavioral scale, which ensure objective assessments of comfort and titration of medications like dexmedetomidine. These tools are only as good as their consistent application, so I ensure all scores are documented during handoffs and integrated into care plans. For instance, a declining PEWS score might prompt me to call a rapid response, while a stable PRISM score could reinforce the current treatment plan. My proficiency with these systems allows me to deliver data-driven, patient-centered care in high-stakes situations.